Thanks for the invitation for presenting today. So what I'm going to talk about is nothing about substantial results, but about the methods and about the exploitation of the data that we generate within the scope of Exposome studies. And what I'm going to reflect on is basically the journey that we've taken from the initial project that we were involved, mostly with Roel and with Remy, who was there earlier on, and basically what were the key challenges that we faced and how we did address them and what solution we proposed. So this is pretty much the conceptual framework we're operating under, and this figure is probably celebrating its 1000th time it's been presented, but basically the idea is that we've got 3 blocks of data that we're interested in. We do have exposures that do get embodied and do generate an internal signals. These exposures may also have an effect on health. So this is the overall construct that we're interested in. And the aims of the first round of Exposome project was really to try and disentangle which kind of approaches that we could take to first, and that was the focus that we had with Roel in our project, to profile the internal exposome. And with Remy, we also worked on what kind of approaches we should apply to qualify and characterize the external exposome. So although the system was and the data were very, very different, on one side we were dealing with super wide data sets with multi-omics data, a large number of measurements made on a smaller number of individuals, while in the external exposome it was far sharper data sets with lower measurements, but usually much more observations. So despite that discrepancy and changes in the correlation structure within the data, we found that the same kind of approaches were important to get the most of the data, and they were relying on multivariate modeling mostly. Then the second generation of Exposome project came in, and the idea was to basically consider the pleiotropic effect of the exposures, as in an exposure not having a single effect on a single omic, but having multiple and complex signatures across the omes. And importantly, that all the omes were contributing together to define the individual risk profile. So we needed to shift from a layered approach to a more integrative, multi-layered approach. And finally, the key element that we also wanted to highlight is that we were not dealing with a single exposure, but with an ensemble of exposures that are articulated within domains, and that these domains are co-occurring and interacting in very complicated manners. So this is what we wanted to account for when we wanted to develop analytical tools. And this defined 4 main priority questions that we had. One about complexity reduction, to try and get from the data some latent structures or latent information that would simplify the data for us to understand it a bit better. A second stream of analysis which related to feature selection. Among the wealth of information that we have access to, what are the key factors that we're interested in, either for understanding the embodiment of exposure and or for looking at the future risk of chronic diseases. A third aim was about data integration. So we have heterogeneous sets of data and how basically can we visualize their complex correlation and mostly assess their redundancies or complementarities. And finally, the fourth aim that we faced, and the challenge that we faced, was relating to mediation analysis, try to identify what is a direct effect of an exposure from what is a embodiment and which of the embodied signatures do have an effect on health. So that was really about mediation analysis and causal modeling. So I'm going to go very quickly on each of those aims. So starting with complexity reduction techniques, where I'm going to show 2 very brief examples of first devising composite scores for summarizing biological health, and also exposure profiling of large population, taking as an example the UK biobank population. So the UK biobank population, as you know, is a very large cohort study in the UK with 500,000 people and with a wealth of information, including detailed history, linkage to health registries, so having information on incident disease and so on, and biosamples from which a lot of biomarkers were generated. So in that concept, we followed up the idea of the allostatic load, where basically repeated exposures to adverse stresses is leaving an imprint in your body, and it generates a physiological wear and tear that ultimately may have an effect on health. And so to do this, we used very classical biomarkers from which we generated a score by simply binarizing the distribution of these biomarkers, and looked at different systems and see how they were contributing to health. So basically, we calculated those biomarkers based on these composite scores based on 30 biomarkers that were from 5 different domains, and we looked at the distribution of the score, here by sex, men and women here, by age, and the coloring represents the social class here as measured by education. And you can clearly see a very strong gradient of this score leading to a poorer health in lower education, irrespective of gender and irrespective of age. We also looked at the distribution of that score in the whole population, which is in red here, and in the people that went on to develop a cancer after enrollment, who are in blue. And you can see that the incident cancer cases had a slightly right-shifted distribution in the score, which may be indicative of an association with the incidence of either cancer or CVD. And this is an analysis that we've done. So basically looking here at the score on the top, and here are the subscores, but we're not going to focus on this. And you can see that there is an effect of the score in men and women for the incidence of cancer. And here there's a gradual adjustment strategy, and you can see that this effect is attenuated while you start adjusting for education, behavior, BMI, and medical history. And then for cancer, it's not significant anymore the moment you adjust for BMI. Well, if you look at cardiovascular disease, it's still attenuated, but even in a fully adjusted model, there is an association. So that is telling us that the score is adding to these established risk factors to predict the onset of CVD. So that is highlighting the usefulness of these kind of scores when you want to assess the risk of certain conditions, and that kind of resonates with what we were discussing yesterday about aging. These are alternative measures of aging that we could use. Then complexity could also be, reduction could also be used to get a better grasp of the exposure profiles of the individuals. And so here the idea is taking tens of measurements of exposures in the UK Biobank and try to identify within that population people that are sharing similar exposure profiles. So we did that by using clustering approaches. So we tested several algorithms, and here are the results for the best one. And you can see here that we identified in the UK Biobank population an ensemble of 8 clusters that were overlapping, at least in those first 2 dimensions. But then we looked at their characteristics, and we can clearly see that the clusters, so here is the cluster membership, and we're looking at which of the original exposures are contributing to the cluster membership, and you can clearly see a differential definition of those clusters. So although overlapping, they're well determined, and they're showing some exposure contrast. And then if you look at their biological signatures, they're quite different. So in this plot, we're showing that the proteomic signature of the cluster membership is quite different. So this is showing that there is an embodiment, a differential embodiment in those different clusters. And here we also related the expo type or the cluster membership with different health outcomes, and we can see different risk profiles. So overall, this told us that you could use this gross clustering approach to get an idea of who looks like whom in the data. And from this, you can identify exposure profiles that are related to biology and subsequent differential health risks. You can extend this work at the ecological level, and instead of clustering individuals, you cluster location in Europe. So this is a work that we've done in Expanse. And basically, this enabled us to identify 6 big expo types that were pretty much exploring the gradient of rural versus urban exposures across Europe. And so you had very far away points that looked like in terms of exposure profiles. Then when it comes to viable selection and integration, so that's the second stream of analysis that we had to do, we went towards the concept of stability selection. So usually when you're doing feature selection or when you're doing these kind of approaches, you're focusing on your statistical performances and you want to maximize your prediction. Here, what we wanted to do, the idea, was that we wanted to calibrate the model in such a way that what you find is more likely to be reproduced in another study. So we combine those penalized models with resampling, so that basically the results that we had were not driven by potential outlying observations. So basically it's a very simple approach. So instead of running a simple lasso, you do that multiple times across. So in the example of regression, you can do a lasso regression. You don't do it once, you do it on multiple subsamples of your population. And then you count the number of times a variable has been selected. And what you deem important as a variable is not the variable that is yielding the best performance, but the one that has always been selected as the most important one. It's not uncorrelated because normally the ones that are actually predictive are going to be more selected. So you end up with something that is more reproducible, and we've shown that it's behaving much better in case of correlation. So the only cost you have is that you have not to calibrate one parameter which is controlling the size of your model. You've got another parameter to calibrate which is also controlling the stability of your model. And these are correlated hyperparameters. And what we propose in our work is to jointly calibrate those. You can apply this for regression models, so to identify predictors, a sparse set of predictors that is complementarily predicting your outcome. But you can also use this for graphical models, and I'm going to show you some examples. So this is an example that I purposely took away from the Exposome field, because these models are very useful not only in Exposome. Here was a pure predictive paper that we published some time ago on the PRS, UK Biobank, for looking at the prediction of a CAD using a PRS. We saw that there was a slight improvement of the prediction by 2% in the C statistics, which we thought was not great. Some other people thought it was great, and then the idea we had in this paper was to use very simple biomarkers that we have, the biochemistry data and the hematological data that are measured in routine in hospitals, and try to see if those data, easy to get, whether they had a potential for improving the prediction. So we used our stability selection approach, and here are the results that we had for men, and we identified 12 variables that were jointly and complementarily contributing to the prediction of CAD incidence. So of course, within those 12 variables, there was a polygenic risk score, but independent of the polygenic risk scores, we identified quite a few biomarkers, including cystatin C, CRP, and apoprotein, some good biomarkers that are not difficult to measure. They were improving the prediction by more than the PRS itself. So that's for the illustration of the feature selection. Now about data integration. So we're moving towards a regression context to a more of a graphical model context, where the idea is not looking at the association between sets of variables and an outcome, but you're looking at the relationship among your variables. So in that stupid example, you've got 4 variables. You have the relationship between 1, 2, 3, and 4, 2, 1, 3, and 4, and so on and so forth. So you've got P minus 1 relationships to investigate, and because we're not 1 and 2 and 2 and 1 are the same in our non-causal framework, then you've got half of the variables of the relationship to estimate. So the only question you have is, you've got a large number of relationships to estimate, and which are the ones that are important? How does it work in practice? So you have a set of variables, so you've got P variables, so you've got a matrix of variance covariance P by P, and this is the information that you have. What you want is to identify the pairwise correlation across in that matrix, which is needed to fully represent that big matrix. So you want to get rid of redundant information among the wealth of relationship that you have to look at. So for instance, and this is an example of a smoking-related CPG sites that we identified in a paper with Ruhl a long time ago. So if you want to look at how they correlate one with each other, so that's 265 CPG sites, then you end up with 35,000 edges to look into. So this is the too big of a dense problem that you want to look into. And so when you are doing those stability selection network, then you end up with a network which is far more sparse, where all these edges are able to basically reproduce the full variance covariance that you have in that very, very dense graph. Then you can extend that, so this is just for a single block of data. Then if you have 2 blocks of data, so taking this example, adding 420 smoking-related genes whose expression was associated with smoking, then you can do that blockwise calibration of the multi-omic network, and you end up with a sparse network here, where you have a multi-omic composition, so where in the blue you have the CPGs, and in orange you've got the transcripts. You can see here in that network, which is, was the smoking-related signals that just were referring to, that this guy here is LRRN3, very central. If you want to move from one part to the network to the other, you have to go through LRRN3. And that's the only gene whose methylation was changed with, in relation to smoking, whose gene expression was also affected by smoking, and whose gene expression and CPG and methylation levels were correlated. So this is also lending plausibility on the topology of the network. And if you map onto that network established pathways, so in that case the stress response, you can see that the genes that are involved in the pathways for the stress response are close by, meaning that the topological, the topology of the network is very, very related to the biological proximity of the features. Again, lending plausibility on the findings. So I'm just going to show this very, very quickly. So we applied this to a lung cancer study where we had 3 omes, methylation data, proteomics data, targeted proteomics data, and metabolomics data. We run, in the first instance, a stability selection approach for the protein, identified 7 proteins associated with lung cancer. We extended this from 90 proteins to 500,000 variables in the methylation data. So we run our lasso on the 500,000 CPG sites and identified 49 CPG sites associated with lung cancer. And we did the same with our metabolomics data and identified 51 metabolic clusters associated with lung cancer. Now the question is, with those 107 features, are they all saying the same thing or are they complementary? So this is what the network is going to help us to understand, and it's going to tell us what is complementary among those 107 variables. So we calibrate that piecewise, and then you end up with that multi-omic network, which is telling us that indeed of the 107, not all of them are useful, and you've got a multi-omic module here, which is very interesting. We extended this, so that was just for discovery, in a more of a causal framework. So here the idea is that we've got 3 blocks of data. We do, well, 4 blocks actually. We've got the confounders here, but we don't care here. We do have external exposures, we do have biomarkers, and we have health outcomes. The idea is to estimate, using those variable selection approach, direct effects. So basically identify which of the biomarkers are associated with the outcome, which of the exposures are associated with the outcome, in a model that will mutually adjust for everything, yeah? So you're identifying the edges, basically ending up in that blue square. And then the second step is to identify within those biomarkers, which are the ones that are actually associated with exposures. So you want to see within those interesting biomarkers, which part of it is related to the exposures. And that's a way if you want to identify mediators and estimate mediated fraction of the effect. So this is the results that we've produced for CVD UK Biobank. So that's just in women. We have identified that among the hundreds of exposures that we were looking to, that are organized in 9 domains here, we've got these ones that were associated with a direct effect on CVD incidence. And some of them were, well, and all of them were also at least associated with one of the biomarkers that were influential here. So here you've got the mediated effect, here you've got the total effect. And so basically that's a representation, and that helps us identify potential mediators and potential pathways related to complex exposures. So that was a kind of a hypothesis generation, kind of causal-ish work. And we also focused within the EXPANSE project on more formal mediation analysis, and we just published this year in Exposome journal a review on the methods that we could be useful for mediation analysis in exposome research. And we did a pilot study here, which is unpublished, but that I'm going to show the main results of, where we basically have the exposome articulated in domains which are time-resolved, if you want, with early life exposures and so on and so forth, ending up here with embodiment and health outcomes. And the idea here is to identify first which are the, the associations with, which exposures are associated with health outcomes and which ones are mediated through a biomarker. So we identified, how am I doing time-wise? Speed it up. So we identified that the attributable risk is over 20% for the three outcomes that we were interested in. So that's all-cause mortality, CVD, and COPD. It was slightly lower for COPD. And there was a consistent contribution of mental and physical health, along with resources and behaviors, to the understanding of the risk of these health outcomes. And then when we looked, sorry, it's a bit small, when we looked at the mediated effects, we saw that social factors were mediated through biomarkers for all the three outcomes. So that was suggesting a strong embodiment of these social experiences. And that the effect of behaviors, which is here, and anthropometry and of those two main exposures on CVD and COPD was also mediated by a biomarker, but not for all-cause mortality. So that is quite interesting in understanding the role of these different exposures through embodiment towards these health outcomes. This work is preliminary, it's not finished, and it basically relies on the way you define this block here and the causal constructs that you're putting here. And if you change this, your result will change. So you have to be a bit certain of the hypothesis you're making when you're making this construct, which sometimes could be a bit challenging. For instance, we've been discussing with Roel about whether we should remove or not some of the boxes, and I think we should. So this is open discussions. But in some cases, you don't know. So this is where we tried, and that's a paper that also was just accepted a few months ago, where we looked at complex AI deep learning models to basically learn from the data whether we could identify likely DAGs. So can we prioritize from data possible causal links within the wealth of information that we had? This was a very, very complex paper, very, very complex set of models. So Salome did a huge work in comparing 20 very complex models with trying to summarize them and their performance in a very neat way. Of those, we identified one that was performing better called Taboo. And from this, you can basically end up with a summary plot, which would be like what you have over there, where you have here all the variables of interest. So this is based, by the way, sorry, on UK Biobank data. And here we're representing the variables that are included in one DAG as a result of this exploration. And then you can have the marginal, so you have the probability of this variable being in a DAG is above a certain threshold. And then you can look at if it's in a DAG, with which other variables is it connected to. So that's helping you to understand piecewise the complex causal relationship that could be supported by the data that you have. Again, very complex and requires a lot of fine-tuning, requires a lot of pre-run and pre-testing of the models. So in a nutshell, I hope I've convinced you that doing exposome analytics is not the matter of running one model, but you're basically tapping into a very large range of methods, ranging from clustering, composite score definitions, to stability selection, graphical models, and so on. So this is not a finished business. So for instance, when it comes to complexity reduction, what we're working on for the moment is to enable, so a limiting factor of clustering and of these approaches is the dimensionality of the data. So we're trying to extend those so that they can accommodate large data sets. So we have a methods paper on consensus clustering for sparse models, which is doing this, and that will be useful for endotyping. So instead of having categories of people based on their exposure, you have them based on their molecular profiles. For stability selection, we are for the moment restricted to linear models, and we are currently extending it so that it models the effect of co-occurring exposures. So we do have a version of that stability selection approach for models within interaction terms. For conditional independence networks, as I showed, we show these nice pictures. They tell us some stuff, but it's sometimes good to get more information from those. So joining them with community detection algorithms could also be useful, and try to understand which regions of the network are more informative is important. And causal modeling, high dimensional mediation analysis is a hot topic. We're starting to think about it, but that's definitely a lead for future work. Also, very importantly, related to what René said in the first day, what we miss is good models for longitudinal data. So we could use longitudinal data, do mixed models, and estimate inter-individual variability better. Fine. But looking at trajectory is a key challenge, and I think extending these approaches for more than one measurement and looking at the trajectory rather than the single point is really a key challenge that will make a difference. These are just the papers and the packages where you can find all the information you need for these models, and especially this one, which is very easy to read, where you've got exemplar data sets, and it's very simple. This is the group who generated all these great results. And if you're interested, just a bit of a promo, we're organizing a short course in September in London, where we're going to teach most of these methods to you. So I thank you for your attention.
Thank you very much for the presentation. Oh, that's loud. I'm Marie-Céline Schulte from the London School of Hygiene and Tropical Medicine, Epidemiology and Population Health. And my question is around your mediation methods. Mm-hmm. Did you use G computation?
Yeah.
Okay. And did you use single mediator models, or had you tried sequential mediator models?
Both. We did both.
Sequential. So, yeah, I'd love to hear more of your thinking around mediator-to-mediator interaction. Mm-hmm. Well, time variation.
No, this is single time. Yeah, absolutely. But yeah, thanks.
Thank you. That was wonderful. I'm a pediatrician, Bob Wright, Mount Sinai. My question is somewhat practical. So, and I confess that was very, very impressive, but I don't really understand it. I don't have a mathematical background. But from a practical perspective, and I'm asking your opinion, do you feel that this level of complexity in an exposome study, knowing that the exposome is highly contextual, that the exposome in London is different than the exposome in Bordeaux, is going to affect replication? Because we will be held to a standard that we have to replicate findings. And what are your recommendations for being able to do that in a systematic way?
Well, it's a difficult question. Some of the results that we have are, for the first part on the clustering, it's going to be extremely difficult, because you get your cluster membership in a given population, you get it in another population. It's going to be very difficult to compare them. You can have some hints on whether they're capturing the same things or not, but that's tricky. For the other analysis, based on stability, that's purposely trying to optimize that replicability, I would say. So I think we're on the good side for this one. For the expo typing, it's more complex.
If I can follow up on this question, actually there's this paper published recently using some clustering methods in CSF proteomics for determining the different Alzheimer's disease subtypes. Mm-hmm. And actually they validate and replicate these patterns and clusters in different cohorts. So I think, although it's complex, there's biological signal there, of course not individual ones, but multivariate ones that can be reproduced in other samples.
That's great. I guess my concern is reviewers of grants are going to not recognize just how contextual the exposome is, and maybe replication, there should be a standard for it that allows for that contextual differences across population.
I guess when it comes to exposures and looking at the external signatures and the external factors, then heterogeneity is huge and context specific. And we had that discussion yesterday at dinner. When you go into biology, which is I think what you were saying, you're hoping that the pathways are actually closer to the ground truth. And so basically once you've got that triggered pathway, you should be able to, if it's causal, you should detect it anywhere. That's what we're looking for, actually. Thanks.